We'll start with the lecture, Know Your Anticoagulants Before Regional Anesthesia. The speaker for the lecture is Dr. SANDEEP MUTHA, sir. I request our chairperson and co-chairperson, Dr. Muralidhar Joshi, sir, and Dr. Kalpana Kulkarni to please come on the stage. Dr. Muralidhar Joshi, sir, is present head of department and director at pain management at Virinchi Hospital, Hyderabad. His area of special interest is pain education and interventional pain management. He is the first to start fellowship in pain management in India. He is the first to author textbook of pain management in India and also the first to start e-learning in pain management in India. He has received award of academic excellence 2010 by ISA. Dr. Kalpana Kulkarni Madam is professor at RCSM Kolhapur and is the past HOD at DY Patil Medical College Kolhapur. She has done fellowship in pain management and presented many papers and posters and has been spokesperson at national and international journals. Welcome. I now request our chairperson to please introduce our speaker.
Okay, thank you for your words of introduction, as well as thank you for giving me this opportunity to chair this session. I am happy to introduce Dr. SANDEEP MUTHA. He is director at Pune Anesthesia and Critical Care, director at Mediparv. He held many positions at ACTA, ISA Pune, AORA and ASO. He has special interest in teaching cardiac, bariatric, regional anesthesia, thoracic echocardiography and new technologies. Trekking, hiking and natural photography are his hobbies. I hope he will keep you all awake. The topic is excellent, and I request Dr. MUTHA to start his speech.
Thank you, ma'am. Hello. Okay, I will be talking on anticoagulations and regional anesthesia, and after that I'm going to present a small video of 3 minutes and introducing a new device to you all, which you can use in your post-op ICU, in CMO, in ICU, in anywhere where you are giving oxygen therapy. So coming to anticoagulation, anticoagulation is known for ages. In our old literature, Hindu literature, there are anticoagulants which were given for different diseases. We know that anticoagulation is given for heart disease, for venous thromboembolism, peripheral vascular disease, post-TKR, post-THR, a patient who is sedentary for a very long time, they are also given anticoagulants. So it is being used very rampantly. And this rampant use is going to cause, or is causing some problems with our techniques, what we do as anesthesiologists. So anticoagulants can be antiplatelets, anticoagulants, thrombolytics. Challenges for the anesthesiologist is very great, and we have to weigh the risk and benefit. So the risk and benefit, what we have to weigh is between the major bleeding risk and the atherothromboembolic phenomena. So there's a very fine line in between these things. Anticoagulants are the drugs which slow down the process of making clots. And antiplatelets are the drugs which prevent the platelet aggregation. So there is a difference between anticoagulants and antiplatelets. I will be dealing with both of them. According to this 2022 European journal, the ESRA guidelines, they distinguish them into vitamin K antagonists, direct oral, low molecular heparin, unfractionated heparin, aspirin, and P2Y2 inhibitors. This I have added to it, that is a natural. Coming to the history, the modern anticoagulation started in 1930 with heparin. Then in 1950 came warfarin, which has been very commonly used. 70 to 80 came the low molecular heparins. In 90s came the direct thrombin inhibitors like beviluridine. Then in 2002, they came with a factor 10A inhibitors, that is fondaparoxine. 2010-12, they came with again direct thrombin inhibitors and factor 10A inhibitors like dabigatran, rivaroxaban, and etc. These are the antithrombotics which are used. Antiplatelets prevent aggregation of platelets. There will be some repetition of slides or repetition of data because of different guidelines which are there. So antiplatelets are either acetylsalicylic acid like aspirin, thienoperidines like clopidogrel, ticlopidine, or prasugrel, GP2B, 3A inhibitors like tirofiban, Riopro, which we call abscessimab, then phosphodiesterase inhibitor, and the direct inhibitors of ATP, that is ticagrelor and cangrelor. They can be direct, these are the newer ones, these are direct acting oral anticoagulants, and these are used very rampantly in different conditions, and sometimes we don't know the name and the patient is on anticoagulants and we start giving anesthesia to these patients. They can be factor 2 inhibitors like dabigatran, factor 10 inhibitors like rivaroxaban, apixaban, or betrixaban. They are used in post knee replacement, post THR initially. Then now the horizon increased to venous thromboembolism, pulmonary embolism, non-valvular AF. There is a reversal agent which is available for these drugs, like hydroxymab for dabigatran and andexanet alpha for the rest of the oral anticoagulants. These are the herbal ones. We should be aware of this because many patients are on herbal medicine. I had gone to Crawford Market once in Mumbai. In one shop, they had these oral anticoagulants, and there were many people taking it from him. So they are in a rampant use, and we don't take the history of this. They can be garlic, which looks like this, ginkgo, which looks like a fruit, and ginseng, which is the root. And what is available in Sangli is turmeric, which has curcumin and which is a very good anticoagulant, which has been used in ages in Hindu literature. Whenever you talk about anticoagulants, you should know the intrinsic system and the extrinsic system. Intrinsic system consists of factor 12, 11, 9, 8, and 10. The extrinsic system consists of factor 7 and then 10. Then comes the common pathway, where prothrombin is converted to thrombin, fibrinogen to fibrin, and then the fibrin and platelet clot is formed. Why, as anesthesiologists, we are concerned about these things? It may be because of intraoperative bleeding, coagulopathy, you are giving regional anesthesia, so your needle prick can cause bleeding. If the bleeding is caused near the nerves, there is compression of the nerves, so it can lead to, there is a problem of deep regional anesthesia, or a neuroaction anesthesia can lead to epidural hematoma. Then post-operatively, the patient can bleed, like if you have done a TURP and the patient was on anticoagulant, then you may have to give 2 or 3 times bladder wash to remove all the clots. And is this thing irreversible? So what can happen? You can have a epidural hematoma, you can have a hematoma near the nerves, the cervical hematoma which was there, the hematoma near the median nerve, or there can be subcutaneous hematoma which can occur. All this can cause post-operative problems. In one of the articles where perineural hematoma may result in a nerve inflammation and myelin damage, they stated that hematoma adjacent to the nerve can lead to a nerve injury and inflammatory changes. So why this is important? Because if there is no heparin and there is a traumatic puncture, the chances of epidural hematoma is 1 in 220,000. But if you have given heparin, it goes to 1 in 70,000. Same thing with spinal. A traumatic puncture, 1 in 320,000. And if it is a traumatic puncture with heparin, it can come to 1 in 1 lakh. One more thing which you have to remember is if heparin is given more than 1 hour after the puncture, the chances of hematoma are less than if it is given less than 1 hour after the puncture. So neuraxial anesthesia and peripheral nerve blocks in patients on anticoagulants, they stated what are the causes for this. This can be intraspinal hematoma because of trauma, anticoagulant, antithrombotic, thrombocytopenic patients, neoplastic disease, liver disease, and alcoholism. Incidence, which I told earlier, in the recent literature, when they started doing MRI and this, they found that this incidence was not this low. The incidence of epidural anesthesia, epidural hematoma was 1 in 21,643 patients, and in elderly it was 1 in 3,800 patients. This is alarming. And if the patient had abnormal anticoagulation, then it was 1 in 315 patients. So many of the patients may be asymptomatic but have a little bit of hematoma in the epidural space. Coming to some of the drugs which are commonly used, aspirin. Aspirin is an acetyl salicylic acid which irreversibly inhibits COX-1 and COX-2 inhibitors. What is this COX required for? It converts arachidonic acid to PGH2. where PGH2 is responsible for formation of thromboxane A2, that activated form, and which is responsible for platelet aggregation. If this is not formed, then there won't be any platelet aggregation. The T half is around 3 to 6 hours. Its irreversible effect can last to 8 to 9 days. But the recovery depends on how is your platelet manufacturing in the body. If your platelet synthesis is fast, that is around 10% per day, the recovery will be faster. The safe dose is 75 to 150 milligram once a day, and you may expect around 1 to 1.5 times more bleeding in a major surgery. We should be cautious in specific surgery. It should not be stopped in all the surgeries, but for some specific surgery like neurosurgery, ocular surgery, intraspinal surgery, and TURP, it should be stopped adequately, that is 7 days. New recommendation, you do not stop for other than these 4 types of surgeries. NSAIDs like diclofenac, though they have a COX inhibition, they don't have much of an anticoagulation effect, but the platelet function can come back in 50% can come back in 6 hours and 100% in 24 hours. So that's not much of a problem. Thienoparidines like clopidogrel and prasugrel, they are irreversibly inhibit the ADP receptors, that is P2Y12. It prevents influx of calcium, which prevents the activation of GP2B3A platelet receptors, which is required for stabilization of the platelet rods. So if this is given, this is not going to happen. Clopidogrel 75 milligram per grams, the 60% platelet function can go down in 6 to 8 hours. And with prasugrel 60 milligram loading dose, it can come down by in 2 hours. So ticlopidine and clopidogrel acts on the P2Y12 receptors, which prevent the influx of calcium, and then the aggregate things occurs. The acetylsalicylic acid will prevent arachidonic acid to thromboxane A2 formation. Coming to the other drugs like ticagrelol and cangrelol, ticagrelol is a reversible non-competitive ATP inhibitor, which binds with the G protein of P2Y12. The T half is around 8 to 12 hours. The peak action is in 2 days, and it lasts for 2 to 3 days. But cangrelol is an irreversible direct inhibitor, but it's very short acting. So if you say 95% block comes in 2 minutes, the T half is around 3 to 6 minutes, and the recovery can be there in 60 to 90 minutes after stopping the infusion. Heparin, which we are using day in and day out, but there is a problem. If you don't see the vial well, then you can land in trouble, because there are 2 vials which look same. One is 1 ml contains 1,000 units, and the other one contains 1 ml contains 25,000 units. So, sorry, 5,000 units. So we have to see the vial well, or keep only one type of vial of heparin in the hospital. So heparin is unfractionated heparin, which inactivates factor 2 and 10A. It is widely used in multiple surgeries. It can be used IV or subcutaneously. It has a reversible agent, which is called protamine, which can be given in 1:1 ratio. Heparin is not absorbed orally, so it should not be given orally. If it is given subcutaneously, it acts in 60 minutes. If it is given IV, it acts immediately. Within 3 minutes, the activated clotting time can reach the peak. It is metabolized by heparinase and excreted in urine. So what does it do? It activates the plasma antithrombin 3. The complex binds with the clotting factor and inhibits all these factors. There are some other effects of heparin. The adverse effects are like bleeding, heparin-induced thrombocytopenia, alopecia can be there, osteoporosis, etc. So heparin increases the risk of bleeding, 7 in 342 patients according to this paper, and this dependent on the needle placement, if the placement was done less than 6 minutes after giving heparin, or there is a traumatic puncture, or any other anticoagulant was added to it. We can monitor this with using ACT, that is activated clotting time, or APTT, which should be less than 40 seconds. So whenever you take the patient for surgery, heparin has to be stopped 6 hours pre-op, and after removing the catheter, before removing the catheter, it should be stopped for around 4 hours. This is a study by German Society, Belgium Society, American Society of Regional Anesthesia, and American Society of Chest Physician. This is a too busy slide. Small thing, it is NSAIDs should not be discontinued except for those 4 reasons. Then ticlopidine should be stopped for 14 days, clopidogrel 7 days, GP2B inhibitor 87 to 48 hours in advance. If you give a subcutaneous heparin, 4 hours period is there. In 4 hours the action comes down, so you have to stop it for 4 hours. Coming to low molecular heparin, which we have been using a lot, they are again 2A and 10A inhibitors. It peaks in around 3 to 5 hours, and you can do APTT, thrombin time, ACT, but nothing is specific for this, and the sensitivity is less. You can do an anti-factor 10A assay if it is available in your hospital to check for the efficacy of low molecular heparin. The reversal agent, protamine can be given to this to neutralize the action on factor 2A, but the action on factor 10A is not neutralized by protamine. This we have seen earlier, that chances of epidural hematoma is very high if you are given low molecular heparin. There are multiple cases with 40 cases and 60 cases in these papers which showed that the incidence were very high. Fondaparoxine, again, it is a polysaccharide specifically binds to antithrombin 3, which is a high affinity. It can be injected subcutaneously, excreted unchanged in kidney. Coming to the very commonly used anticoagulant, that is warfarin. It is coumarin derivative. It is oral anticoagulant. It inhibits 2,3-epoxide reductase enzyme. It prevents conversion of oxidized vitamin K to reduce vitamin K, and it interferes in vitamin K dependent coagulation factors. Half-life is around 36 to 42 hours, and you can check the action of warfarin using INR and PT. If INR is 1.2, the factor 7 is around 55% active. If it is 1.5, it is only 40%. And if the INR goes more than 1.5, the factor 7 is around 20 to 40%, and there is more risk of bleeding. Vitamin K, FFP, PCC is prothrombin concentrate, which can reverse the action of warfarin. And in one of these studies, they reported that the epidural hematoma was there after 3 days post-operatively. So you should be very aware when you are using warfarin. Then, so the warfarin acts here. It prevents epoxide to hydroxyquinolone formation and the activation of prothrombin. How do you manage the patient on heparin preoperatively? Preoperatively, you have to stop 5 days preoperatively. 2 days before the surgery, you do INR. If INR is more than 1.5, give vitamin K. If you have an emergency surgery, give vitamin K around 2.5 to 5 milligram orally or 10 milligram IV. Give FFP and PCC. If there is high risk of thromboembolism, then do a bridging therapy with low molecular heparin or unfractionated heparin. The last dose of low molecular heparin should be 24 hours before the surgery, which should be ideally half dose. And unfractionated heparin should be stopped around 4 to 6 hours before surgery. Post-operatively, in low-risk patient, you can resume warfarin in first day, but in a high-risk patient with a minor surgery, you can start low molecular heparin after 24 hours. In major surgery, you start after 48 to 72 hours, and assess the bleeding before starting. So what is bridging therapy? According to ASRA, the preoperative stopping of warfarin, then starting with low molecular heparin or unfractionated heparin, INR, which we are told earlier, and the postoperative period, again assess the bleeding and start the drug. So this is called a bridging therapy to stop warfarin and start with shorter acting drugs. So in short, 5 days before you stop, 5 to 6 days before, 3 days before you think of bridging it if the patient is of high risk of venous thromboembolism. And after surgery, in a minor case, you can start on first day. In a major case, you can start after 48 hours, that low molecular heparin. So this is the comparison. I'm not going to because of lack of time. Now, direct acting oral anticoagulants, they are factor 10A, 2A, that is dabigatran, and factor 10A, that is rivaroxaban, etc. Dabigatran reversely blocks the catalytic site of thrombin and prevents the conversion of fibrinogen to fibrin. So, in that way, it will prevent the formation of the clot. It blocks the activation of factor 5, 7, 9, and 13, and platelet aggregation. Onset time is around 0.5 to 2 hours, T-half is around 12 hours, duration lasts for around 24 hours, is low liver metabolism, so 80% of it is excreted unchanged by renal clearance, and there is a reversal agent, that is edoximab. The factor 10A inhibitors, they prevent the fibrin formation and inactivates the platelets. It increases the PT and APTT, but that increase is not much. It is metabolized by cytochrome P450, and 35% of it is cleared by renal, that is unchanged. These are the different dosages for different procedures like venous thromboembolism or stroke or acute venous thromboembolism or extended in DVT or pulmonary embolism. Coming to neuraxial anesthesia with these drugs, one of the papers stated that it's high-risk intervention and bleeding complication which can be devastating. So we had to discontinue these at least 5 half-lives of the drug. This was recommended by in 2018 update of ASA guidelines. The European and Scandinavian guidelines stated that it is 2.5 times interval, that is 48 hours, or the drug concentration remaining in the body should be less than 3.1% of the blood peak levels. You have to check for the anti-10A inhibitors. And if the renal clearance is low, then you have to avoid neuraxial anesthesia or deep nerve blocks when the patient is on dabigatran. So in short, we have to stop for the low-risk patient dabigatran around 24 to 36 hours, for high-risk 48 to 72 hours, restart after 24 to 48 hours, stop for regional anesthesia 5 days before, and restart for regional anesthesia 6 hours after the surgery is over. Apixaban, rivaroxaban, endoxiban, these can be stopped for 24 hours for low risk, 48 hours for the high risk, restart after 48 hours, and around 2 to 3 days after for the regional anesthesia, and to restart after removing the catheter around 6 hours. What are the investigations we can do to check for the anticoagulation action? These are the different. For intrinsic pathway, you have APTT or ACT. For extrinsic pathway, you can have PT-INR, platelet aggregation assay, TEG, and ROTEM. So this is for the extrinsic pathway, that is PT. For PTT can be used for the intrinsic pathway. If you see this slide, where IV heparin has been given, where APTT increases, with subcutaneous heparin, only APTT increases. With warfarin, there is increase in the PT. For dabigatran, there is slight increase in the APTT and PT. But with aspirin or any other drugs, these don't change. So PT and INR are not good for the patient who are on aspirin or NSAIDs or ticlopidine, clopidogrel, etc. What are the point of care coagulation monitoring other than PT-INR? We can have a qualitative platelet count or a functional platelet assay or platelet mapping assay for checking for the action of aspirin and clopidogrel, which are very commonly used drugs. Or you can use fibrinogen level, TEG or ROTEM. So TEG-ROTEM is a viscoelastic property of blood clot, and it's measuring and mapping the mechanical impedance and related to the formation of the clot. It will check about the whole blood coagulation system, concentration of the clotting factors, influence of platelet, influence of fibrinogen level, effect of heparin, and fibrinolysis. So how it goes? This is the graph which you get when you do a TEG. There is a clot initiation which will measure the thrombin generation. Then there is an angle and elevation, that is the clot formation, which will tell you about how is the fibrinogen level and the platelet function. Then there is a maximum amplitude, that is known as clot strengthening, which will tell you how stiff is the clot. And then there is a fibrinolysis, or clot stability and the lysis index. All these will tell you at this time what is happening to the patient and what should be given to prevent or to improve the coagulation of this patient. So taking an example, if there is a delayed clot formation, it can be a heparin effect or the factor deficiency. You have to check for the ACT. If ACT is high, then give protamine or repeat the test. If there is a weak clot formation, it can be because of antiplatelet like aspirin and clopidogrel. The treatment is FFP platelet and possibly cryoprecipitate. So if you want to emerge in an emergency, you want to reverse the action of anticoagulants, so PCC can be used for orally acting anticoagulants, warfarin and low molecular heparin. Edoximab can be used for dabigatran. Androstenate alpha can be used for rivaroxaban and the other oral anticoagulants, even for fundoparoxine and enoxaparin. The last drug is not available with us. For emergency reversal, for urgent, what is urgent surgery? Urgent surgery is where you have 24 hours with you to control. And emergent surgery is where there is less than 1 hour. So if warfarin has been given, you have to stop warfarin, give vitamin K. Then check for INR. If INR is 2 to 4, you give PCC around 25 international units per kg or FFP around 10 to 20 ml per kg. If INR is between 4 to 6, the PCC is given at 35 international units per kg and again FFP. INR is 6, more than 6, then it is around 50 international units of PCC and the FFP with vitamin K. In case of trauma, you can use a tranexamic acid added to it. You have to avoid using PCC in patients who had a history of heparin-induced thrombocytopenia because PCC contains a little bit of heparin in it. So that can be a problem if the patient has HIT. Coming to regional anesthesia again, there are two types of regional anesthesia, that is the deep nerve blocks and the superficial nerve blocks. Deep nerve blocks, you have to be aware that there can be bleeding and it won't be under your control. So you have to avoid deep nerve blocks in patients who are anticoagulated. Superficial nerve blocks can be given in these patients, and the superficial nerve blocks are like superficial cervical plexus block, erector spinae block, or any facial plane block which is not near to the vessel can be used in these patients. In one of the papers where perioperative guidelines for antiplatelet anticoagulants update, so they stated that timely intervention, PT-INR should be done, removal of intervening catheter if the INR is less than 1.5, and neurological status has to be assessed regularly. Okay. In this paper in 2011, there was no contraindication for aspirin and NSAID. Again, the same thing which I had repeated earlier. Spinal hematoma is a big problem for us. So there are multiple papers which have stated that there were permanent paraplegia in these patients who had epidural hematoma. So we should be aware of it and don't take it lightly. They can be a temporary or permanent disability with epidural hematoma. These are the different factors which are more common in these patients. It can present with return of sensory and motor deficit several hours after the spinal epidural has worn off, or the epidural action is not wearing off for more than 3 hours. There is a chance that there is a epidural hematoma there. So we have to have a high index of suspicion. You have to again and again check for the neural deficit, do a MRI and USG to check if there is a hematoma, and if there is a hematoma, do a surgical evacuation. Why? Because if it is less than 8 hours, the chances are good of recovery. But if it is between 8 to 24 hours, the chances become bad. So they can be permanent paraplegia if you don't take the action immediately. This is a busy slide where there is a epidural hematoma and how to go about it. If you suspect that there is a high level of suspicion, blockade is for more than 1 hour after the block regression has started, then last medicine has been given more than 3 hours ago, or there was a difficult spinal or difficult epidural, focal neural deficit is occurring, then you go for the specific treatment. Same thing for peripheral nerve blocks. If there is a peripheral nerve block and you are thinking of a hematoma there, you have to do a clinical evaluation, electrical evaluation, and radiographic evaluation. If the hematoma is present, you do a surgical evacuation. If you don't see any hematoma, you have to continuously do a neurological examination. If the recovery is good, it's fine. If the recovery is not good, then surgical intervention can be done later on for these peripheral nerve blocks. This is again how to stop, but I'll be telling you about this in a very simple manner. When you are using unfractionated heparin, hold 4 to 6 hours pre-op, restart after 1 hour. This is low dose. Hold the catheter removal for 4 to 6 hours, restart 1 hour after, and T-half is this. If you are using a low dose subcutaneous, then again, the same thing is there. Only thing is you can restart the subcutaneous heparin immediately after the procedure. But if you are using a high dose, you have to start only after removal of the catheter. And preoperatively, you have to stop 12 hours before, and the PTT should be less than 40. Warfarin, which we've seen earlier in detail, with a low molecular heparin, you have to stop 24 hours before, restart around 24 to 72 hours after the surgery, and hold for around 12 hours before removing the catheter. Coming to oral, that is rivaroxaban. Because I get a lot of phone calls from many of my colleagues, if the patient is on rivaroxaban, that is Xarelto. Okay, the patient is on Xarelto, and what to do? You have to hold 72 hours pre-op. You have to restart around 6 hours. Hold for catheter removal around 22 to 26 hours. So this is the drug which is causing a little bit of problem in anesthesiology because they don't know about this drug. Most of the people don't know about this drug and what to do if the patient, you are going to give a regional anesthesia to these patients. The other drug is dabigatran. 120 hours or 5 days before surgery, you have to stop this drug, and you can restart around 6 hours after. Aspirin, clopidogrel, prasugrel, which we have talked earlier. Coming to Riopro, that is apaximab, 24 to 48 hours before you have to hold, and you have to avoid when the catheter is there in situ. So, knowledge and pharmacokinetics and pharmacodynamics will allow practitioners to anticipate difficulty and accept what are the complications which can occur. In case of anticipated risk of bleeding, like epidural hematoma, it's better to avoid it. Rapid diagnosis intervention is the crux of this management. So you have to be vigilant with a high index of suspicion if you are giving a deep nerve blocks to these patients who are on anticoagulation, and you have to take the action very fast, that is surgical evacuation of the clot or decompression of the nerve. Thank you. Now I will be telling you a small video of a machine which we have developed. This is the machine which is giving oxygen by nasal cannula.
Prananiti installation or
We
setup.
named it Prananiti.
Prananiti is plug and play with existing oxygen supply central or cylinder system and binasal cannula. Installation step 1. 1. Connect power plug
Stop.
at rear of machine.
Okay. This machine, we give oxygen by nasal cannula. What this machine does is it senses your inspiration and delivers oxygen only during inspiration. So it delivers oxygen with a higher flows and higher pressure than what is coming from the oxygen source. How it does? It senses with the nasal cannula. This is the nasal cannula. A regular simple nasal cannula. It senses through this nasal cannula what is the inspiration. And as soon as the inspiration starts, it gives a peak inspiratory flows. The respiratory rate has to be less than 40 for this. If it is more than 40, it doesn't work very well. When it gives the flows will be of a higher rate. Suppose you have kept an inflow of oxygen coming from here at around 2 liters flow per minute. then the outflow will be, as the peak inspiratory flows can go around 3.5 to 4 times, that is around 6 to 8 liters per minute. So it goes with higher pressure also. What pressure we are getting from the flow meter is around 0.06 to 0.08 bar. When it is delivered to the patient, it is delivered at around 1.5 to 2 bar with 100% oxygen reaching through the nasal cannula to the nasal tip. Now there is an indrawing of air by a Venturi effect and there is dilution to it. So I measured the FiO2 which is going to the patient. The FiO2 going to the patient was around 60 to 75%. So I was also surprised with that. What we did was, to a sidearm agent gas monitor, we attached an infant feeding tube and passed it through the nose to the oropharynx and checked for the inhaled and the exhaled oxygen concentration. So inhaled oxygen concentration was around 60 to 75% and exhaled was around 40 to 50%. So what is the dead space? We'll have around 40 to 50% of oxygen at the end of inspiration. Then what we did was we checked for the somatic and the cerebral oximetry. The somatic oximetry jumped from 45 to 60 within around 2 to 3 minutes in obese patients whose BMI was more than 40. So I did around 50 to 60 patients like this continuously, and all had a good increase in the somatic oximetry. So you are increasing the oxygen which is delivered to the tissues. You are using very low oxygen as an inflow, delivering oxygen at a higher pressure and higher flows, which is improving the oxygenation of the patient. And also it has some alarm systems, like if the nasal cannula comes out or patient stops breathing, it will give you a no inhalation alarm. So you will come to know immediately that the patient is not breathing. So you just adjust the cannula. The first breath the patient takes, the alarm stops. If the oxygen supply coming from the wall mount stops, then again it will give a dry run alarm, and you know that the oxygen supply is not there. You check for a cylinder or check for the...
Dr. MUTHA, I think a lot of people have to travel, catch flights, please.
It's only 1 minute.
Yeah, please, because 3 minutes video is saying, yeah.
Last safety mechanism is, if the machine stops, whatever oxygen is coming from the wall mount is going directly to the patient, so the patient won't be devoid of oxygen. I use this in post-COVID patients, lung fibrosis, in obese patient with OSA, in mild pulmonary edema patients, then in cardiogenic shock patients where the respiratory rate was less than 40, they improved the condition very fast. So this is a new device which we call Praniti. It is now patented and we have started using it. Thank you.
Thank you, Dr. MUTHA.
Sorry for increasing the time.
Yeah, no problem. I think that they can ask questions during the tea time. That's not a problem. A lot of people have to catch flight or here and there and all. Thank you once again. That was a great lecture, and followed by, we appreciate innovation also. Most welcome for that one. Thank you so much. Over to you, Desk.
Thank you so much, sir. I now request our chairperson to please felicitate our speaker, Dr. Sandeep.
Felicitate the chairpersons.
Thank you so much. Dr. Joshi, sir, we are entering in our 75th Platinum Jubilee celebration. I would like to take this opportunity and felicitate Dr. Ashok Deshpande, sir. I request Dr. Murli Joshi, sir, to please felicitate, sir. Dr. Ashok Deshpande, sir, is alumni GMC Nagpur, practicing anesthetist in Sangli since 40 years. He has worked in regional anesthesia, epidural double catheter technique, received President's Oration at Jodhpur 2017. He is a speaker at state and national conferences. He has worked in anesthesia, cath lab, CCU and in charge of skills lab at Bharti Hospital Sangli. He has held many important positions at MSc ISA and West Zone ISA. He is past president of MSc ISA and at present GC member of ISA National. We are very honored to have you, sir.
या सगळ्या आजच्या CME मागचा प्राण म्हणजे देशपांडे सर आहेत.
so much, Joshi sir. Deshpande sir, please I request you to wait for some time. I would like to call Dr. Joy Shankar Jana sir on the stage, and I request Dr. Ashok Deshpande sir to please felicitate. Dr. Jana sir is Associate Professor and Senior Consultant. He has hold positions like Governing Council Member ISA National Headquarters 2016-2019, Governing Council Member ISA Maharashtra State 2012 to 2016, Honorary Secretary AOA Pune City, past Treasurer ISSP Pune City. He is the first in India and Asia to give anesthesia for uterine transplantation. We are very honored to have you on the stage, sir. Thank you.
Thank you so much, Deshpande sir, for giving me this honor. And on this occasion, I would like to announce for the next coming national elections, I'll be contesting for the post of National General Secretary. So with the blessings of the seniors, my teachers, and all my friends, please support wholeheartedly.